free. So I think I don't see anyone else coming down the hall. So I think maybe we'll get started. On time and respect everybody's busy schedules. Oh, yeah, the shirt's in here. So we are live on YouTube, just so everyone knows. There's some people watching on YouTube. They can just hear you. Okay.
Yeah.
Yes.
Okay.
Let's get started.
Yeah. On time as much as possible, and hopefully I don't trip over any of these cords while I'm up here as well. But I'd like to start off by welcoming you all here and thanking you for joining us. All of you that are in person, this is really exciting. We also have individuals who are streaming online, so welcome to you all. As we kick off our fall caregiver programming, we would first off like to acknowledge the land on which we gather is Treaty 6 territory, the traditional territory of the First Nation and the homeland of the Métis. Thanks again for joining us for our first AGE-ucation workshop series of 3 being offered this fall. This is my colleague, Leslie McCullough. She's been handling a lot of the tech side along with Christy, one of the staff at the Saskatoon Council on Aging. And we also have a few nurses in the back. They are 4th year student nurses and they are with us for a few months. We're very fortunate to have them, so we'll welcome them as well. Okay, so just a little bit of background information. We work in the Caregiver Information and Support Center, which is a program of SCOA. And SCOA is an abbreviated form of the Saskatoon Council on Aging. The Saskatoon Council on Aging is a community-based non-profit organization that promotes positive aging for all in an age-friendly community. Our mission is to promote dignity, health, and independence of older adults. Our mission is to, of older adults through education programs, services, resources, and policy advocacy. Nothing like a little bit of nerves when you're standing in front of people, so I'm sorry about that. So before I introduce today's presenter, I wanted to go over some quick housekeeping. The presentation will be approximately 30 minutes, followed by a Q&A period. And for individuals who happen to be joining online, we will be monitoring the chat, so feel free to put your questions in the chat, and we will do our very best to respond to those questions in a timely manner after the presentation. There also, as you came in, you may notice that we had some refreshments. So if you haven't grabbed anything, please feel free to do that at the end of the presentation or even throughout, that's fine. And again, today after the presentation, if you wanted to wander across the hall, that is where our resource center is located. So the Saskatoon Council on Aging's resource center is located within the Fields House here. And we have the Great Wall of Resources there, so feel free to check that out. And if you have any questions about membership and you aren't already a member, please feel free to just ask any of the staff in the Resource Center, and they'd be happy to help you set up a membership if you're interested. I believe it is $25 per person for the year or $35 for a couple. So now that's all for housekeeping. I'd like to introduce to you today's speaker, Arden Moore. Arden is a community educator with the Saskatchewan Health Authority, presenting on the topic of providing an overview of services provided by Client Patient Access Services, also known as CPAS. Client Patient Access Services exists to provide a single point of entry to healthcare services, both in community and in hospital. And today, Arden will be addressing how the professional staff with CPAS work with individuals, their families, and other healthcare providers to ensure appropriate access and case management throughout the continuum of care. So without further ado, we'll give Arden a warm welcome.
I might have nerves too. So my name is Arden Moore, and I do work at Client Patient Access Services. I've worked there for quite some time as an assessor coordinator in acute care in the community, and a number of years ago I took the educator position. So CPAS has been around for a really long time, and it's changed and evolved over time. So I'm just gonna scoot over here so I can see my slides. Our vision is to promote a client-friendly community, and the purpose of CPAS is to help people who need acute, end-of-life, rehabilitative, maintenance, or long-term care to remain independent at home in the community for as long as possible. We encourage and support assistance provided by family and community partners. And we contributed to the health authority's goals by ensuring appropriate access through the transition of care. Our goals or principles are the people who have the greatest need get service first. People have the necessary information to participate in and be accountable in decision-making. Services are integrated and responsive to changing needs of the individual, and system needs are also considered. So system needs meaning system needs of acute care, system needs of home care, system needs of long-term care. So we work within all of these different systems and are accountable to the needs of what the system requires as well. So we are case managers who work at CPAS. Case management is dynamic. It encourages collaboration with clients, with their families, with their caregivers, or their supporters, or their neighbors, or other agencies who may be involved with that client as well. So what are we? So we are social workers. So that's what our background is. We're nurses, occupational therapists, or physiotherapists. Those are the backgrounds for the people who work in our department. And we're accountable for providing case management services to clients and patients within the Saskatoon Health Authority. Coordinators provide information and facilitate access to lots of resources, both internally within SHA, but also externally. So we see people, and sometimes what we see a client or family may need isn't always what we within the system can provide. It's sometimes making a connection to another resource, like private care homes, or like assisted living, or like community living division, other services that aren't within SHA. And we are not just, we don't refer to everything that within SHA. There's a group of things that we make direct referrals to, but we can certainly help sometimes facilitate access or open a door, push out a door for people. So single entry point with case management service. We provide for a variety of community service and resources and coordinate that access within that case management approach, with the hope of not duplicating service. So within SHA, you have lots of different services. So you might have physiotherapy that you can get with chronic disease management, or at outpatients in the hospital, or we have direct links to physiotherapists that if a person needs can come out to their home. So the goal of part of our work is if a person can get services elsewhere, they can get out to those services and it's most appropriate, then the goal would be for people to go that way rather than to come to some of the services that we would have. So we're trying not to duplicate a lot of what might be out there already. So how do we provide service? So primary health care coordinators are assigned to healthcare networks. So a number of years ago, we kind of switched within primary health care to not just look at Saskatoon as a whole, but they've divided Saskatoon and area into 5 different networks. So you've got north, south, east, west core, and different needs. There are different needs in each of the areas of Saskatoon. Lots of the same needs, but also different needs within each different area of Saskatoon. We also extend outside of Saskatoon. So our work follows within that old SHA boundaries, which probably about an hour outside of Saskatoon. So we might go to Warman and Martinsville or Dalmeny or Radisson or Aberdeen. So just because you live out in this, what we call suburban areas, doesn't mean that you can't have access to some of the services that we might provide. So we work 7 days a week. Most of our staff work Monday to Friday, both in acute care and in primary health care, so in the community. But we also have staff that do work on the weekends and help facilitate discharges from acute care, as well as if somebody needs something on the weekends, there's somebody that can support. We follow provincial guidelines. We follow the home care guidelines that are put out by our government, and we have lots of documentation and requirements that we have to follow. So this is just a little bit of the map of the different areas, and you can see that this is Saskatoon, but it goes beyond Saskatoon, the area in which we cover. All right, so what kind of services? So we have an intake service. So if a doctor calls or a doctor sends a fax, we have an intake team that takes that information and does an assessment and either sends people just to a nurse if you just need a Band-Aid done, or if there is bigger needs and bigger questions, they can make a referral to the community primary health care services. And then we have the bulk of our staff right now are our primary health care coordinators. So those are the people that can come to your home and see your mom or your husband or your kid. If there's something going on and you feel like you need some help. We also have another branch that's called the continuing care branch. And so they are the people who manage the long-term care wait list. They're the ones who manage transfer list, the day programs, community day programs, of which we have 5 that we make direct referrals to in Saskatoon, and also direct client funding. And then we also have our acute care coordinators. So there's acute care coordinators who work on every ward in every hospital and can help make plans and help facilitate discharges. Oh, and we also have people who work in the emergency rooms. So they're called the quick response team. They all work for us in a different sort of manner. About a year and a half ago, we went from 1 department to 3 departments. So we're now acute care, primary health care, and continuing care. But we still work together. I have to make a referral. That's our phone number. So 655-4346. And I think most of you took pamphlet. And there's also a fax number that physicians or anybody can fax information to with whatever their concerns are. So it's just a little map. Anybody can make a referral to us. Doesn't have to come from a doctor. It doesn't have to come from the hospital. Anybody can make a referral. Really, the only thing that we need is for the client to be willing as much as what they're able to be willing, and to participate with us in our assessment process. So this is just acute care community. Just kind of shows a little bit of a map. What to expect when you call intake? You're going to get a lot of questions. We ask a lot of questions. Sorry about that, but we do. You're going to need to know who is the person's name, their whole name, the real name. So their first name, their last name. We need a person's HSN number, so their health card number, and their date of birth. Those are really important numbers for sure. You're going to be asked about allergies. You're going to be asked about diagnoses of the individual. You're going to be asked about medical history. What language does the client speak? How tall they are, how much they weigh. They have a special diet. You're going to be asked about hazards that exist around the client's home. So is it safe for you or for the staff? Do they have pets? Does anybody smoke in the home? You're going to ask lots of those kind of questions to make sure that both you and the staff are safe. You're going to ask about client function. So what's the client's ability to manage their activities of daily living? Activities of daily living with things like getting dressed, how a person toilets, how they mobilize, how do they manage, what can they do, and what do they need help with. They'll ask about the person's abilities to do daily living tasks like cooking and cleaning, managing finances, all of that kind of stuff. I'm gonna ask, why are you calling? What's their reason? I think this is sometimes a really tough question for people to know the answer to. Sometimes there's a problem, and it's really hard to figure out what that problem is. If you're able to clearly identify what the problem is, that's great. But sometimes you need a little help doing that. And intake is pretty good. The staff is really good, and they'll help that's part of why we ask a whole bunch of questions, is try for our own selves to figure out what's going on and what, in a quick little assessment, might be helpful and supportive to people. But for you, if you're calling, it's about, what do I need? What isn't working right? What isn't good going well for my person? What do I need help with? Anybody can make a referral. And it's important to be able or prepared to answer as many of the questions at intake, because if you give them lots of information, it absolutely helps them make some determination about where your next step would be. Some referrals get directed just to single service, so just to a nurse. And a lot of the people that come to us get referred to a primary healthcare assessor coordinator. And that's the case management. And they would come and they would do a home assessment, so they'll come to your home or the client's home, and we do an assessment called the MBS assessment, and they would do that with you. The other thing is important to know who we need to communicate with. Sometimes we should always work so our client is the center of care. That's how we want to work and focus. But in reality, a lot of times people aren't always able to manage to be their own contact person. So who else is in that person's life who is the circle around that client? that we can communicate with and help support that person. So this just talks a little bit more about case management, and our job is to help job pitcher. So we ask a million questions, but it's about looking at what a person is able to do and what are those unmet needs that they have. It could be unmet needs like basic things like getting dressed. It could be they don't have the right equipment to get in and out of the bathtub. It could be things like housing. They don't have housing. They don't live in the appropriate environment. We don't find housing for people, but we can certainly give people information about resources within the greater community. So we are the link often between the client and community, and trying to facilitate that between acute and community. So we do direct referrals to a lot of the primary healthcare services, not all of them. And these are the ones that we make a direct referral to. So these are the people that can make referrals to CPAS, which is really anybody. And these are the ones that you have to come through us in order to get access to any of these resources. So under the umbrella of home care, case management falls. We also have a group of therapies. So we have community occupational therapy, physiotherapy, speech and language, a teeny touch of recreation therapy, not a lot. It'd be nice if we get some more sometime. We have some volunteer services, and under that little umbrella falls Meals on Wheels. I almost took out the shopping and transportation because right now after COVID, that's on hiatus, and I'm not sure if it's coming back or not. We have a group, a team that fall under the Seniors First umbrella. They're nurses, and as well as a lot of these therapists and case managers that work to support people who they do a lot of work with CHF and COPD, like people that are fairly unstable. Then we have our home care, what I think a lot of people think is home care. So that's the nurses who might change a bandage or help with catheter care or help with medication. And we have also home services. So those are the people who help with that functional stuff, like getting dressed or toileting, meal prep, that sort of thing. We also have some home care pharmacists that support all of us, but primarily the nurses in terms of looking at a person's medications and making sure they're safe and functional within the scope of what nursing does. We do have nurse practitioners, didn't used to, but we do. It's really quite lovely to have them. Nurse practitioners function at a different kind of level than what a typical nurse does. And they can help us with things that we didn't have access to before. We have other programs under that umbrella called for children with highly complex care needs. We have an individualized funding program, which provides funding for people who would qualify. So basically they can set up their own services. Collective funding, we have also nutrition services. So we have a couple of clinical dietitians that work with us as well. We have 5-day programs, community programs that are supported by the health region, as well as under the continuing care umbrella. We do the assessments for people who go are admitted to nursing homes. Also do planned and unplanned respite for people in the community, and they do direct client funding as well. That's kind of the single service scope. But we also work with a lot of this. So a lot of what we do, you know, we have a fairly large umbrella of services we need to know and understand eligibility criteria for, but we connect to the bigger world a lot. So we connect to mental health and addiction services sometimes, or Cosmo, or mobile crisis if we need them. There's lots of other things that we can and do reach out to, not just for us to support, but for everybody to try and support. Sometimes we are the main case manager, and sometimes we're the secondary case manager for clients. So there's lots of different resources outside of us in the community as well. Skip that. So what to expect when somebody comes to your home? So the coordinator would come to your home and again ask a lot of questions. Some of the important things to think about, and I'm not sure if it's something you guys will ever have on your agenda to do as topics. Power of attorney, big deal, really big deal. Advanced healthcare directives. I will leave that to you guys to think about doing things like this, because those two things are really important. Power of attorney typically is about a person's finances. Who is that person that would manage a person's finances if your person isn't able to do it? It's really difficult, but we shouldn't ever do it. Make a power of attorney if a person isn't cognitively able to do it. So it's always important to do it well in advance of a time when a person can't make decisions. Advanced healthcare directive, important. I'm a control freak. I want to know, I want to be able to make my decisions for myself for the time in my life when I'm not able to make those decisions for myself anymore. So advanced healthcare directives, power of attorney, big deal. We're going to maybe ask you questions about private insurance. There's lots of support you can get through private insurance, whether it's equipment. Sometimes, depending on your insurer, it's things like private home care services. It depends on your insurance if you have private insurance. We'll ask about treaty status because under people who have treaty status have different rights under the federal programs. SGI, WCB, we'll want to know about that because we need to collaborate. We don't want to provide something that another source is providing as well. That's about being accountable to our system so that we're not duplicating what we can get for somebody elsewhere. Can ask lots about memory, hearing, any kind of diagnosis. Has anybody had a capacity assessment done? Communication, hearing, vision, comprehension, behaviors and management of those behaviors. So one of the things that have seen lots over the years is when I go out to see people, particularly in terms of long-term care, but other things as well, is for people who are struggling at home with their person. It's amazing how caregivers and supporters just do it. You adjust whatever that your person, what their changes are. And so understanding that you have readjusted or changed to accommodate the new world of your person, it's important to be able to say, well, you know, what's happening and what you've done to change that. So sometimes that's a medication change. Sometimes that's your own behavior change. Sometimes you readjust the layout of your apartment. Sometimes you lock door locks on your doors. I'm not sure always people really recognize how much you as caregivers or supporters change what you need to do in order to help your person remain at home. So being mindful of that, because you're going to be asked. It's good to think about those sorts of things ahead of time. So social history, what's the person's social history? Tell me your story. I like to get to know people when I'm in an assessment. That's usually the first place that I start. I love finding out who you are before I delve into all the other stuff. But what's their involvement in social world? Are they isolated? Makes a big difference for a lot of people. Sometimes it doesn't. Sometimes people are quite happy not to be with anybody else, but sometimes it's a big deal. Who's their informal support? So who's your person? What does that informal support do? Informal support are unpaid supporters or unpaid caregivers. So who is that person? What do they do for the client? We're going to ask about those instrumental activities of daily living, cleaning, cooking, financing. How does a person do their ADLs, those daily basic things that we do? We're going to ask about mobility. I'm going to want to watch you walk when I go up there. I want to see how you get out of your sofa. I want to see how you walk down the hallway. I'm going to want to go into the bedroom and the bathroom to see what that layout is. And it's not to snoop, but it's to look at how do you move within the space of your home? Do you need some equipment? Are you unbalanced? Are you weak? What does your bedroom look like? Can you get in and out of bed? Is it too cluttered? In the bathroom, do you have equipment in the bathroom? Do you need help in the bathroom? Again, they're going to talk about incontinence, so bowel and bladder incontinence and how that's managed. Again, diagnosis. We're going to ask about pain, falls, smoking, swallowing, consumption, how much you eat and drink a day, oral health, skin wounds, foot issues, formal care providers, who else is involved? It can't just be us, can't just be you. Who else is involved in the story? Sometimes it's just a family doctor. Sometimes it's outpatient services. Sometimes it's chronic disease management. There's lots of others that can be involved in the story. It's important to know that. And any kind of recent hospital or emergency visits. So our goal is to understand what the client is capable of doing. So what can they do? Sometimes we as caregivers step in and do rather than letting the client do. That's not necessarily a bad thing, but it's important sometimes to know what the client can do for themselves and also who is doing whatever the task is. Our goal is to figure out what a person's unmet needs are and we can't fix everything, but help us figure out within the scope of what we make referrals to, but also help guide you to where else you might look to get some support for your person. After the assessment, the coordinator will go back or will talk to you about what they see. So it's called care plan. So often when I'm doing an assessment, I'm writing my little care plan over here. And then before I leave, I go through that with the client and family. And sometimes the client and family think my ideas are great. And sometimes they think I'm full of beans. So, and sometimes we agree on some things and don't agree. And that's totally fine because our goal is to support that client with whatever it is that they feel that they need. So come up with a care plan. And then we would make referrals to those single service places like occupational therapy or home care, nursing, or a CCA or a social worker. After the assessment, we do the assessment, provide it to our service providers. We might call you back with more questions. One of the other things, make sure that you have the contact information. Most of us have business cards, so you should get a business card. That's who you call. If you don't hear back from us, or if you don't hear back from the services that we make referrals to, please call our coordinator and just say, hey, what's going on? I will say right now, wait lists are super long. Unfortunately, we have some extraordinary long wait lists, particularly for therapy services. Long-term care has a very long wait list. Day programs have just opened, so, but they're at a lesser volume than they were before. So sometimes the wait is long, but if things change and if you need more help, then please let us know. And we can take a look at moving things along. So caregiving, being the supporter, you're part of the team. In fact, in my worldview, most of the time you are the most important part of the team. Because most people couldn't stay at home if they didn't have somebody there to help them stay at home. Caregivers or supporters come in lots of different ways. Sometimes it's a spouse and sometimes it's a daughter. Sometimes it's a mom. Sometimes it's a neighbor. They're not all the same, and we don't all, as a caregiver, we don't always provide the same level of care. Sometimes the caregiver is the caregiver to make appointments. Sometimes that caregiver is actually doing physical hands-on care for the person. Sometimes they're doing wound care, bathing, all of that sort of stuff. So what our goal is always to promote as much independence as possible for that client and that situation at home. But sometimes that situation at home or that caregiver that surrounds that client needs more help. And sometimes it's really important to ask for that help. Whether that be help to provide physical care, like having a CCA come in and help do some of, I don't know, help somebody get up in the morning. Sometimes it is about saying yes to having your person go to long-term care so that you can continue to have that other relationship with your family member. Somebody else can care for them and you can just be their daughter. Depends, everybody, I've seen lots of people over my career. Everybody's different. Every scenario is different. Clients are different and their support systems are really different. So all of our assessments are really geared to who that person is and what their story and their supporters are who surround them, because that helps us drive our care plans. So resources. Primary healthcare services are directed at a client needs. And sometimes it means it's easier to continue to provide care. Not quite sure what I meant with that statement, sorry. We might look at things like alternative housing, assisted living, or private care homes, long-term care. There's also, we have social work in the community, and their goal is counseling support. So sometimes the client needs support, but sometimes that caregiver needs support. And if you need help, or if you feel like you need to talk to somebody, having your own social worker or your own counselor to talk to sometimes helps you continue to support that client. Resources. There are lots of resources under that umbrella of what we talked about. So those single service, so the occupational therapy, nursing, long-term care, day programs. There's lots of that kind of services. There's also alternative housing, seniors assisted living, private home care services. There are private home care services out there that do what home care does. They cost more for sure, but that's sometimes something that people prefer. They often, when you're working with private systems, you get to drive the train. When you're working for public systems, which is what I work through, it's often system driven rather than as much client driven. Church community supports out. Lots of people have religious affiliation. Many church communities have a lot of support that exists out there for them. There are a lot of caregiver support groups, both places at church. Whether there's lots, I'm sure you guys have lots of support groups that you have under your umbrella and you make recommendations to. Different organizations have different support groups as well. There's bereavement groups. Our social workers do bereavement groups as well for people whose spouses have passed away under the Palliative Care Program. There are also private day programs. So I talked about our day programs a little bit, but there's also private day care programs as well. They're a great resource and a good, it really gives caregivers a break when you are able to have dad go to a day program and he's got about 3 or 4 or 5 hours, depending on the day program, that he can be there. Mom can be at home doing whatever, just having a little bit of a break. And then if you go back to page 14, there's an awful lot of resources that surround us in this community. It sometimes takes a lot to sort of sort through and wiggle through. And I would say, I look at this and I know most about a lot of these things, but there's still a lot of things out there I don't know about and that are not on this list. There is an awful lot of resource out in our community. So that's all I have to say. Does anybody have any questions? Yes.
Is there a cap on the amount of respite hours that somebody can access through home care?
Yeah. So if we are, first of all, in all of the services that we make referrals to, there is always eligibility criteria. So when we do assessments and we're looking at the care plan, we're also making sure that we're setting people up and you have to be eligible for the service. It isn't, I like to tell new staff that it isn't just because I want something for my dad. It's, I might want something for my dad, but my dad is also eligible for whatever. So that's the difference a little bit between public and private. So yes, 8 hours, sometimes 12 hours if it is somebody who's palliative. I will say too, working in public service, it's very dependent on staffing levels. So during COVID, there was a lot of slowdown of a whole bunch of things, including within home care. So didn't have a whole lot of respite. So depending on the client, depending on the situation, 8 hours probably. Yeah.
In the beginning, you kind of mentioned that Seniors First program. Can you kind of elaborate more on what that is?
Yeah, okay, so Seniors First was developed quite some time ago. It was actually called Home First for a while, and the goal is to keep people at home. Our goal is to promote independence. We want people to be independent as much as possible, but also safe. So so Seniors First is a team approach. So they deal with people who have, fairly unstable medical conditions. They often case manage clients who have COPD, CHF.
Yeah, what, sorry?
COPD
Okay.
or CHF. Not always, but they do support that group of people quite a bit. So there are case managers, so people who do the same kind of work that I would. They have nurses that specifically work in that, as well as occupational therapists and physiotherapists. And their goal, they have very small caseloads, so there aren't a whole bunch of people that are followed under Seniors First, but their goal is to really tightly support that client. Those are often the people that are pinging back and forth to the hospital a lot. So that's a big flag for us, is when somebody's in and out of the hospital. Yeah. So a lot of COPD and CHF clients, but instability and people who would really benefit from that super wraparound, from that really team approach. I think, truthfully, I think all of our clients would benefit from that team approach, but just not feasible. Yes.
What's the, do you provide foot care?
No.
Okay, well, I just noticed on there was something about feet.
Up here?
Well, no, I can't read that, so
Oh,
it was one of the places that said looking after wounds and. feet.
okay. No, we'll ask about it. Foot care is a really big deal. A lot of home care doesn't do.
I can't hear you very well.
No. Do you want me to take this off?
Well, it doesn't matter, you just keep fading out, that's all.
Okay, I'm going to take it off. Might help a little bit. So, home care does not do foot care like foot care, nursing care. Once upon a time they did, but it's not a standalone service either. What I will say, some pharmacies in Saskatoon, if you get medications from, I don't know if they do it anymore, Medicine Shop used to do it. And if you were getting prescriptions from Medicine Shop, they do your toes too. There are podiatrists in Saskatoon. Podiatry services is quite expensive, but if you have foot care issues, it's certainly worthwhile.
No, it's basically just getting the toenails and your feet looked after, you know, especially people that are, haven't been mobile for a while or just can't look after their own, clipping your own toenails and things like that.
Yeah, I don't have it with me, but I do have a list of foot care givers who would come to your home and provide that. Yeah, if you would like.
Is it on the website? Is it on the website?
No, it's not on that website, but I can send it to you if you'd like.
That'd be great.
Yeah, I'll get your
Sure.
particulars after. Sure.
Super.
How do you secure a meeting with CPAS if you're in the hospital?
Okay, so that's an excellent question. So we are now 3 departments, so we're not like one like we used to be, but our work, our systems, our computer work, it's all intertwined and we still function very close to each other. So whenever somebody's in the hospital that's already a client, we are sharing information back and forth electronically or even phone calls. So if a person gets admitted to hospital, you can ask the nurse on the ward, who's the CPAS coordinator, assessor coordinator on the ward, and they can come and meet you. If you need to, if you're already connected to a primary health care, so a coordinator out in the community, you can call them and they can then help you, like give you the name of that individual, whoever is the person in the hospital. They all have phones and they all have pagers. So if you know their phone number, that's great, you can leave a message, or you can call switchboard at the hospital and ask for that person to be paged and they can call you back.
I have a question.
Yeah.
How long do the primary healthcare coordinators follow their patient or client? And does that service, is there kind of a cutoff? And
The only cutoff would be is when they no longer require our service. So we don't do a whole lot of just straight up case management of people who don't access our primary healthcare services. However, it is pretty clear that there are some people out there who do not have a supporter. And we will keep some of those clients on just as case management, particularly if they're the ones that ping back and forth to the hospital a lot and they need somebody.
Yeah, I have a bit of a follow-up question to it as well. So if somebody is under the care or is utilizing these services, and they kind of go a ways, or sorry, let me reframe this. If they've had an assessment and they have a coordinator working with them, and let's say they don't qualify for long-term care, but they're kind of on the cusp, at what point can they reach out again, and will they reach out and contact that same person that they initially spoke with?
Okay. So if a person doesn't qualify for long-term care, doesn't mean that we will discharge their file. Usually if we're talking about long-term care with somebody, there's something cooking. So there's probably other things that we are already still involved with. They may have home care going in and providing, you know, physical care, may have therapy involved. They might be going to day programs, so they'd still be our clients. If things change, people really should always reach back to their assessor coordinator. So yes, when you see somebody at home, they should be giving you their contact information. Doesn't mean that we don't have a changeover in staff, but it does mean that that phone number that you got on that card should go back to whoever is managing that caseload. Yeah. Or you can always call our intake number, although don't tell my second. They don't want a whole bunch of calls that they don't need to. Yes,
So what's the cost per visit?
nothing. We're free.
Okay, so is there any, for any length of time, is it prorated for, you know, like if you need extra services or anything like that from you, is there prorated or? Is it
Okay, so
completely?
yeah, okay. So services that cost money, and again, always, it's about, we are accountable to clients and families, but we're also accountable to a system that's public, right? So it's always looking at what's happening for the client, what are their needs, what are their unmet needs, and then determining the care plan. So then some things are free. So the things that are free are all of the professional services. So everybody who has to be licensed. I have to be licensed, nursing has to be licensed, all of the therapies do OTPT, social work, speech and language there. It doesn't cost you anything. Sometimes with therapies like OT or PT, they may make recommendations in terms of equipment. Sometimes you can get that equipment if they write you a little note, a requisition at the abilities council. Some of that you can get for free. Some of that you would need to purchase on your own. But if you have private insurance, sometimes that will cover it too. Mm-hmm. So for the most part, like it's just equipment wise for them. The services that cost money that we touch is the home services piece. So the physical hands-on care. So somebody helping somebody get up in the morning, somebody having a bath, somebody helping with a meal. Meals on Wheels is also a billable service. And that service is prorated depending on what your income is. Okay. So home care already is hugely subsidized by the government. Mm-hmm. But then there's also a subsidy for people if your person has help in the morning to get up in the morning, as well as a bath once a week. Depending on the amount of service, yeah, there is subsidy available.
So what's the average length of time that you would give to a patient coming in the morning and helping them dress or?
It's very client dependent. Home care does their own scheduling. I don't schedule for home care. But it's usually they start scheduling just straight up basic, very short AM care, 15 minutes. 15 minutes. It's quick home care services,
Doing,
depends.
how can people get dressed in 15 minutes?
That's where they would start. Depending on the individual, it can go up in time. So really, it's very client specific. That's typically, they bill in 15-minute increments. So that's where they start. And if a person needs more help, which is why sometimes public or private service is better for people than public service, because you get to drive the train when you hire somebody privately, as opposed to when you're using the system.
So say somebody coming in to help for a bath or something like that, would that be 15 minutes or would that be?
No, it's usually a half an hour to start with, and again, dependent
Yeah.
on what that client's needs are, right?
Okay.
Yeah.
Good, thank you.
Yeah, you're welcome. The other thing that does cost people money is day programs. Again, super subsidized by the government. I think, I don't know for sure, I think they're about $10.50, something like that right now. All of the 5-day programs we do are different and run for different amounts of times. And there's the ability to also get taxi back and forth at a really subsidized rate as well. I love day programs for caregivers. I think it's as long as the person is happy to go and happy to participate. I love day programs. It just gives the caregiver.
They're a real bonus. It's a voice of experience here. So
Yeah,
they're a real bonus for people that don't get out really a lot.
absolutely. It's good for your person as well as for you.
Yeah, for sure.
Yeah.
It gives you that extra couple of hours.
Just breathe.
Thank you.
Yeah, for sure. The other thing that hasn't started up again, and my fingers and toes are crossed, is plan respite. So plan respite is also a billable service, not through home care. It's between whoever and the nursing home. And it allows for people to actually go to respite in a nursing home. And let's say my dad, I wanted to go away for 2 weeks in February. We were able to arrange for him to get admitted to one of the homes that does respite, so that you can go do your thing, have your life, and then come back and pick up again. It is not open yet. My hope is that we will get there, but between COVID and long-term wait list, that's really long. I'm not sure when, but I'm hoping that will happen.
So you said it was subsidized for home care. Is there like an hourly charge? Like a
Yeah. Yeah, so home care home services or Meals on Wheels is starting October 1st, $9.24.42. I can't remember. Whatever, it's not a lot
Okay.
per hour for the first 10 hours of service in a month.
Okay.
After that, if people apply for subsidy, so if they have more service than 10 hours a month, then it's based on what their income is. So the client's income, and if they're married, the spouse's income. And so to the maximum of like $530 or $50, I don't know.
And they can call into the access number, like call the CPAS to access the,
They can call it, yeah. And then, but it's always, when you make a referral, really think about what it is your needs are. Be able to identify that if at all possible, just makes it easier for them to actually recognize what it is that you're looking for. And be prepared for lots of questions. We talk a lot.
one more question.
Sure.
Because I talked to somebody today about it. So what is the long-term care rate right now?
Long-term care doesn't have a top to bottom list. A long-term care is a list of people who meet the eligibility criteria for long-term care. So again, their philosophy is whose need is greatest, both the client need and the system need. Right now, there's a lot of system need happening in our hospitals. But there's also a lot of clients who are living with their people, their caregivers at home. So there's a big need there as well. So what I would say is some people get in within a few weeks, and we have people right now who've been waiting over a year. Yeah, not great, but part of the reason that we really try to support people to maintain independence, access other community resources, not just us. There's lots of.
What is the minimum requirement to go on a long-term care list?
Wait list?
Yeah.
Again, that's based on assessment. But really people have to have fairly high physical care needs, like, you know, you're in a wheelchair, you're a lift, often you know, like a mechanical lift, combination of some medical, like fairly medical stuff happening. We also have another group of people dependent, are those people who have cognitive issues and need a secured environment. There are a lot of private care homes out there that have locked doors and can manage that sort of thing. There's lots of things that occupational therapists can go into a person's home and look at how to make it safer and keep the client in the home or whatever. But there are people who really need a secured environment, both because of their behavior or because they're exit seeking or that sort of thing. So I can't really tell you what the, because it's so personal to the person, but really it's heavy care. So I will tell you the hint for eligibility for long-term care is that the care isn't managed in the community. So that's the very first, the person's care is unmanageable in the community. That's the eligibility criteria for long-term care. So I know when people go to panel and they haven't accessed other resources outside of the community, including home care services or even living in a private care home, they often will say, no, you need to try and manage healthcare.
Yeah, do you have access to just some sort of handyman services, like somebody who can change light bulbs or?
I probably do. I will send the whole thing to you.
Okay, that'd be great.
Yeah, you have an email?
Yes.
Perfect. I will do that.
I'm almost wondering if you wouldn't mind sending that to us, and then that way, if there are any others that may
Sure.
have
Yeah.
questions, we'd be able, or we could email that off to them too.
Yeah. Yeah, no, I have to do that. Anything else?
I guess my question is more probably directed to Scola and the advocacy types of activities with respect to the services and experiences and feedback on things, because I've certainly had a lot of experience with my own mother, but now some things are happening with the neighbor, and I've gotten, but there are things like as a caregiver for my mother is very different than a neighbor who's having medical issues, who needs support, has no family in the city. And there are things she's asking me to do that I've had to say, no, you don't give me your MasterCard and your PIN number. You don't do, but it's protection for the caregiver as well as the individual and how to kind of access services for that person who doesn't really think she needs it.
Yeah, so almost having a trust in place or somebody that would take on that responsibility.
Yeah,
other than yourself.
it's just, she's so trusting, and I'm saying, no, don't do that.
She have
And
family?
her family is out of province, a son and daughter, but they're, and I've talked to her daughter, and her daughter's talks to her mother, and her mother says, no, everything's fine. And so, but she's calling me when she needs help, or she's, and I'm already doing all this other stuff with my own mother. And then it's I've had to kind of back off and say, you need to do this, or you need to do that, because I can't do it, and I've contacted the daughter and said, look, this is not good. She is so susceptible to fraud or other things going on, and I'm worried about her. And I will help as much as I can, but I'm already stretched. And I'm a senior myself, and I have other issues I've got to deal with. So it's becoming very stressful.
There is public trustees that can take over for some finances, but usually the best bet is to work it out with the family, and maybe there's somebody else in that circle or that loop.
I say, I don't know if there is, but so I've talked to the daughter, I've talked to her son, but then they call her, she says, no, everything's okay, so they just don't do anything. And the work to do, but in the meantime, she's very vulnerable. She doesn't drive, she doesn't, she's very dependent. And she's looking for somebody to do it for her, because that's what her husband did for years, and now that he's gone, she doesn't want to think about it, she just wants somebody to take care of it. Anyway, that's a personal situation, but it's advocacy around some of those kinds of supports and things that, as far as education, as far as resources for people, in terms of not just fraud prevention, but also how the kinds of situations and things that can come up. Because when she said, here, take my credit card and I'll give you my PIN, and I said, no, I will pick up groceries, and I arranged with her daughter that I pick it up, I send the receipts to the daughter looks after getting reimbursed for what I purchased for her, because I don't want to be in a position where somebody says, you've been mishandling this person's money.
I think in terms of SCOA's role, that's very much on our radar. We were just discussing that yesterday, because a coworker, this happened to her mom too. And so I think every about 6 months, we try and do some sort of learning opportunity. So it's all about education, and that's our motto, just try to present educational opportunities. So she would attend one of our workshops on prevention or something like that, we could start.
It's certainly something that I know a lot of older people in the neighborhood. I live in South Newtown Park, and there's a lot of people who've been there they're in their original houses yet. And you get very concerned about what's going on and how susceptible they are to, people coming around knocking on doors, so we've got a deal on this, or
those phone calls?
oh, yeah. So, and they don't want to hang up on them because it would be impolite. It's like, no. They're not being very polite trying to sell you stuff you don't need. Hang up.
I have a question. When my husband is in rehab right now, so they have done an assessment of our house. But before he comes home, does CPAS come and do an assessment at the house too?
Is he at GRU or is he at City? So there is an assessor coordinator that works at GRU. I'm sure she very much knows who your husband is.
Yeah.
Her name is Kira Head.
Yeah, I know.
Okay.
But I just wondered if CPAS does an assessment before he comes home, so CPAS, if they're coming in, will know.
So what Kira will do
Yeah.
is, I would assume that she will talk to you prior to discharge.
Right.
And talk to you about what's going on, what are the unmet needs, what do you need help with, what does he need help with, and come up with a care plan.
Okay.
And then if between you and her, the decision is that your husband might need help at home, then she would assign it to one of the network coordinators in whatever area the city.
Yeah. Okay, that's good. Thanks.
Yeah, but Kira is your ticket over there.
Right. Good. Yeah. No, I don't care.
Yeah, she's lovely.
I added a little of our key things, so we would really, 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 really appreciate it if you guys fill that out. Just there are some more ideas about the next kind of workshops, and if you have any other questions.
Yeah,
Need pens.
yes, I have a lot of pens.
There are pens, so our nursing students can pass around pens if you don't have one. Again, these evaluations help us to better, I guess, tailor our presentations to your needs. I have been monitoring the chat online and we don't have any questions online, and I appreciate everybody's questions coming in for Arden. She's done an incredible job explaining what CPAS does. And I think if you have any questions, or if you're trying to access CPAS, again, I think that number was 306-655-4346.
Correct, yeah.
Okay.
Good job.
And of course, you can always contact SCOA, the Saskatoon Council on Aging, and reach out for support, resources, and services, and even find out about more programs. We do have our next educational workshop happening on October 27th, and that one will be around it's actually a group called Classic coming in, and they'll be talking about wills, guardianship, and power of attorney. So
Yeah, big deal.
yeah, it's a very important one. So yeah, I
Give a round to Arden.
yes, thank you so much.
I'll let you unplug it so I don't break whatever needs to.
And we still do have more treats over there on the table, so feel free to grab something there too.
And